to continue because don't have time. At the end, last section of the meeting, I know all of us very tired because we have to go. I would like to invite again Dr. Christopher to present his speech. I think this is a very important topic. His topic is those intensive conditioning. Where does it matter in our hematopoietic stem cell transplantation, and what can we do about it?
So thank you for those who've stayed. Maybe some of them will come back. Maybe they're like, the last talk was so stupid I gave that they're not staying for my last one.
They're coming back.
But this is, again, it's like there's, yes, is, you know, conditioning regimen intensity, you know, yes. Then you can say whatever question you want to get the yes answer. So we're going to talk a little bit about, touch on a couple of things we talked about last year, and then look at some particular situations. Again, this is a talk primarily of principles and concepts because there's not a lot of quality data to answer any of these questions. And then I'll finish off with some thoughts of, not data thoughts, but concepts about what we can do. So I'm going to go through some of this quickly, but the blues are allotransplants. So allotransplants primarily still remain a disease of leukemias and related disorders, and those are stem cell disorders, whereas autotransplants are for diseases that are not stem cell disorders in the traditional sense, but something a little bit further along the way. And we're going to talk a little bit about both autos and allos. So the first question is, how do transplants cure people? And it's different for autos and allos, maybe. So in an auto transplant, there's this sort of sweet spot. If this is a tumor, and you know, how much chemo do you have to give to kill the tumor? If you have Hodgkin's disease, you can cure a lot of people just with regular chemo. If you have relapsed Hodgkin's disease, you have to get up into this zone here where the chemo you give is going to kill the bone marrow but also cure the disease. And then there's other diseases where no matter how much chemo you give, you're going to not cure the patient, the disease, because you're going to kill the patient. So that's why we don't do transplants for colon cancer. And it just happens that the drugs that we use for lymphoma et cetera are alkylating agents, and these diseases are sensitive to alkylating agents, and you can escalate chemotherapy a lot because the only limiting toxicity really to alkylating agents to go 10 or 15 times a dose is the marrow. So autotransplants cure by killing with high-dose chemo, steep dose response curve. I think that's the vast majority. You can say, well, maybe that makes them more sensitive to an immune effect later by the patient. We don't have any way of really knowing that. So autos, chemo. Allotransplants, the question is, we've just been hearing, is it the conditioning regimen that's curing them, or is it the graft versus tumor effect that's curing them? And we've had that answer since 1990. Mary Horowitz published the paper showing that it was both. So here we see twins, and these are people with early stage leukemias, a lot of CMLs, and if you do an autotransplant with a twin, identical twin, then there's no immune effect, and you're basically curing those people. Now, that's a lot of relapse, but not all of them relapsed. And so you're curing them just with the conditioning regimen. And down here you can see that if you do an allo transplant from a sibling, then you're going to have less relapse because you have the same chemo effect and an immune effect. But if you take the T cells out of the graft, you deplete the graft of the immune effect, then you go back to having a higher relapse, but you still cure some because of the chemo. So in allotransplants, traditional allotransplants, the conditioning regimen contributes to the cure, and the immunologic effect contributes to the cure. So do we need more intensive regimens than we have? We have, oh, look, they're bringing tea. Bu-Cy and Cy-TBI. I love tea in this country. It's just amazing. Bu-Cy and Cy-TBI are pretty intensive. Do we need something more intensive than that? Yeah, give me one. This will make my talk much better. Thank you, sir. And the answer is yes, because, or do we need, even in the auto setting, do we need more intensive regimen? Yes, because look at this big blue pie here is people relapsing after auto transplant relapse because of the disease, primary disease. After allo transplant, even within the first 100 days, 30%, remember this because the whole talk is about the futility of, waiting. 30% of people die of the primary disease within 100 days of transplant. And if you live beyond 100 days, still 60% of the deaths are from the disease. So we obviously either have to increase the intensity of the conditioning regimen, make it better, or have a better immunologic effect, because we still are failing immensely, even more so with the autos as we see. Now, we talk about transplants, transplanters are like cooks and they all want to, have their own little mix of this and that, throw in a little paprika, throw in a little busulfan, they all want their own thing. But when you come down to it, there's really only a limited, really broad groups of conditioning regimens. In the ablative setting, people get bu-cy, flu-bu, cy or etoposide and TBI, and then the really mishmash of other things. And then the reduced intensity, pretty much everything's fludarabine based, either with busulfan, melphalan, or the Seattle approach. So there's not a lot of difference. And we had this, I think, last year, just remind us that if you make things too toxic, as we saw with ablative transplants and lymphoma, you kill too many people with the TRM. If you give too wimpy a regimen, a very low intensity conditioning regimen in an aggressive disease that everybody relapses, and if you do a haplotransplant in Hodgkin's disease, according to Hari, it's perfect. Nobody dies of transplant, nobody relapses, it's paradise. We'll wait and see. So if we want to make transplants better and we want to increase, and we know that intensity matters to some degree, then we have to make sure that we can keep the people alive through the toxicity. And fortunately, if there's only one thing we've done well in the last 25 years in transplant, it's pick patients better and provide better supportive care. Probably the two most important advancements in transplantation are Zofran and Plerixafor. So, but look at this. I don't think, personally, I'm a pretty good doc. I'm not as good a clinician as Hari. I worked with him for 10 years. He's an amazing clinician. I don't think I can get the mortality down much better, much lower than this. In ablative transplants, 14% of people in early risk disease die of TRM. Every now and then you get unlucky, right? Some bad thing happens. There's a certain amount of this we're just not going to be able to get away from with TRM. And if you're in more advanced disease, obviously we're still making progress, but and it's down about the same. So it's hard to imagine you could get TRM with an ablative regimen down below 10%. That's my thinking. But we're making progress, and I circled this because the death is early. TRM is early. Everything's early. That's bad. So with an auto transplant, what do you pick? Well, what drugs do you have? So we had a BCNU problem in Canada for a while. People stopped selling it in Canada because we were too cheap to pay what they wanted. So then you have to make a different regimen. You can't have beam without the B.
That's what happened to us too.
Yeah, so it's silliness. You want to pick drugs that kill the disease, right? So I say we don't use auto transplants in colon cancer because alkylating agents don't kill colon cancer. They kill lymphoma cells. And all these things that we talked about last year. But you also have to think about all those other things that we know weigh in on tolerability, organ toxicity, comorbidities, how old, etc. For allotransplant, again, these are these things we talked about last year: the patient, the disease, socioeconomic circumstances. What's your healthcare system? Do you get BCNU all the time? And the therapy that you're going to use in total, their prior therapy, their graft, their donor, all of these things weigh in. And we're not going to go into great detail, but I wanted to touch on three things. One, age matters. Age matters because we're getting older, which is good because the alternative is you're not getting older, which means you're dead. But we're getting older, and we're transplanting older patients, both in auto and in allo. And so it doesn't seem like much, But that's like 100 people over the age of 70 having an allo transplant. That's craziness compared to 20 years ago, right, where nobody would be anywhere near that old. And we do know that age matters, even though we can do physiologic age and did you carry a cord of wood in, you're probably good. When you get older, your TRM goes up. So here, TRM goes up. It's a difference of about 8 or 10% between the youngest cohort and the oldest cohort. So getting older does matter. And it limits our ability to apply ablative conditioning, and it even applies here in reduced intensity conditionings. So age is an issue. So we have to think about that. We don't want to wait too long to intervene in a disease. And you have to survive the transplant to be cured by it. So the other thing we have to think about is in the 1970s, everybody looked like this. In the 1980s, everybody started looking like this. And then not in Turkey. People are still looking like 1970s. But in America, they're looking like this and more so. And so how do you dose this? Do you give this guy the same dose per kilo as someone this size? Does your fat have the same metabolism and need for chemotherapy as your muscle and your internal organs and your marrow? And if you look and see, if this is a study where people just, they collected what people did. They gave, this is a melphalan they gave to regular sized people to morbidly obese people. And they could see that they gave more to the morbidly obese people, but actually the dose per size of the patient, they actually gave a lot less to those people. Because they said, well, we're giving a big dose, but, oh, I can't have cookies right now. Thank you. But they didn't give them enough if you based it on their size. And you can see that if they did it by milligram per kilogram, they actually gave way underdosed, potentially, those patients. So you have to think about that, and there's been a whole bunch of ways of adjusting for it. You could give them actual weight. You can give these different modifications, use the ideal weight, use an adjusted weight, use this fancy one that I think is good, but it's too complicated for people. And you come up with these ideas, and they say, well, it doesn't really matter if you're the size of the average person walking around in Istanbul, because you're kind of near your ideal weight. But when you get to America, you're looking at an 8 or 10% difference in somebody who's 70 kilos and who's supposed to really be like 56 kilos. In America, they're 100 kilos. So you get out to 100 kilos, and you're looking at, you know, again, a 15, a 20, you get a huge difference in the dosing. So we have to think about how we're going to dose. If we want to go dose intensity, we have to think about what that means in people who aren't regular size. Okay, the next thing we have to think about is comorbidity index, and everybody knows this, but I just want to remind us of a couple things. It's always different in reality. So everybody thinks, oh, I use a comorbidity index, and if they have a lot of comorbidities, I do a reduced intensity conditioning. The problem is there's the same amount of comorbidities in patients whether they're getting high dose therapy, reduced intensity, non-myeloblative, or autos. And yet the difference is we know that if you have comorbidities and you give an ablative, you have more mortality than in a reduced. So there's something, some intangible thing, which is why we're at the bedside, because we can recognize which patient with comorbidities can still tolerate a high-dose regimen and which patient with comorbidities really needs to have a reduced intensity. So we're not going to be replaced by machine learning yet, because there's something about the bedside knowledge that allows us to still apply intensity and select patients with comorbidities. And this just to show the effect of comorbidities is the same in ablative and reduced intensity. So we're pretty good at picking who should get what kind of transplant. I think that's the message I get from this. The other thing is that not all diseases are equal. So follicular lymphoma doesn't relapse as fast as someone you transplanted after an accelerated phase AML, right? So here's indolent lymphoma, low relapse rate, myeloma, higher, allo, higher rate. And so the relapse reflects chemosensitivity and the immune sensitivity of the disease, right? Some diseases are not very chemosensitive, but they're immune sensitive. Some diseases are the other way around. Some are neither, some are both. And the way we do this now is we look at the disease risk index, which has been revised and made more subtle. And originally from Dana-Farber group, Philippe Armand, and it was revised with the registry. And I'm not going to go through it except that it's more subtle, it's more complicated, and you can see that even for disease like AML, some AMLs are considered low risk, some AMLs are still low risk, and some AMLs have moved from intermediate to high. So it's not so much that they've moved, but that AML can be low, intermediate, high, and very high risk. So it's not just a disease as a diagnosis, it's the disease status. It's not just the comorbidities, but it's the package of the patient at the bedside. It's a complex, it's not whether they weigh 70 kilos, it's whether they're 70 kilos and 4 feet tall or 70 kilos and 6 feet tall. There's a whole bunch of things that we have to consider if we're going to intensify the conditioning or maintain the intensity of the conditioning regimen, because we already know that it contributes to the cure of patients, and it contributes a lot to the cure in some patients. Like ALL, I think a lot of the cure is from the conditioning and less so from the GVL. And we say, well, what does it really matter about the high risk and the very high risk patients? And it matters because these are the people where intensity matters the most, probably. People who have the disease that you need to control, buying time for the immune system to come in. And if you look at this, a third of the transplants we do for AML are for intermediate or advanced disease. Nobody said, I never transplant anybody who's not in remission. Everybody does. Because the 20% of the transplants in AML are in people not in remission. So if we're going to transplant people with high-risk disease, you have to be alive long enough for the immune effect to kick in, and you have to have your disease controlled, so you need intensity. So when does the immune system recover? I couldn't find a good slide that shows that, but what I will tell you is that relapse is early, as Harry pointed out in his last talk. Immune reconstitution is not. We don't have an immune system in day 30 or day 60 that's going to cure you of your disease. A lot of the trouble we have is in day 30, day 60, day 90. Particularly, we talked about FLT3 AML, things like that. Once you get out here, you can see all the diseases are kind of the same. A lot of the relapse is early, and then the immune system can come in and do what we want it to do. So here's the problem. There's a tension. TRM is early, relapse is early, and immune constitution is inversely proportional to the intensity of the conditioning. The harder you hit them, the more toxicity, the more you delay the immune ability to recover. So are we in a no-win situation? And then the question is, does even more intensive condition, okay, so we think all those, we say, well, what if we, not only do we not want to go down, what if we go up higher? Can we go up higher? We're going to look at quickly a couple examples. So here my colleague Mitch Sabloff did this registry study, and the short version is, if you increase the intensity of TBI, you decrease the relapse rate by about 10%. 10% is a lot in transplant to change an outcome. But we know, guess what? That you decrease the relapse, the blue, 12, 13, 14 plus gray, decrease the relapse, but you die of other things. So we haven't really made any progress in that setting. So just simply intensifying the radiation has not panned out in psi TBI. But maybe if it took away the psi and went higher in the radiation and did other things, you might be able to get there. But at least there, increasing it doesn't work. But what if you targeted the radiation? Because you give TBI, you're getting the whole shebang, right? The whole body. But what if you targeted the radiation using a monoclonal antibody linked to a radio signal? And it's hard to know whether that data is not conclusive, but it raises an interesting question, because look at how much radiation they could get to the marrow where the leukemia is. If you radio label it, you can get up to 30 gray, 40 gray to the marrow, but not really increase the radiation above sort of the normal amount to the rest of the body. So that's a potential way. Increase the intensity, but target it to the disease. So then back to the question of, or staying with the question of intensity matters, I think people are familiar with this study. We touched on it last year. The ablative versus reduced intensity CTN trial is an excellent trial. A little complicated because it closed early, but the standard things that we talked about versus the standard things that we talked about in standard diseases in regular people. And what happened? Mostly AML. What happened is the study was closed because there was a survival advantage in the MAC, the myeloablative arm, related to an increase in relapse. The survival advantage, though, was limited to the leukemia patients, and it was limited, it was related, it looked like, to relapse. So again, the myeloablative conditioning cured more people because it controlled the disease until the immune system come in. Or it just happened to cure you with the conditioning regimen and you didn't die of GVHD. And if you look at it, this is a relapse, again, reduced intensity, much higher relapse in both of those settings. So in diseases that are aggressive, we have the idea that intensity matters, some idea that if you could go higher it'd be better, if we could figure out a way to limit the intensity to where the disease is. And I show this because I keep harping on this thing, the badness happens early, and once you get past that, you're curing people in both groups. The immune system can control the disease long term in both groups, but you have to get it, you have to keep it in control long enough for that to happen. Okay, what about large cell lymphoma? I already talked a lot about large cell lymphoma, so I'm going to jump through this quickly, but this just reminds us that sometimes people pick the right regimen and we haven't done anything better in 30 years. So BEAM's been around a long time and nothing's better than BEAM. Just like nothing better than CHOP yet. Nothing's better than BEAM. And people tried, so we said, well, what about, again, the idea, increase. So BEAM's good, let's make it even stronger, because stronger is better because we just keep saying dose intensity matters. But the problem is adding radio-labeled Rituxan, so Bexar, versus just regular old Rituxan didn't make a difference. So either we've already passed that threshold where the disease response curve is such that adding more isn't going to cure any more lymphoma cells, or we just didn't go high enough. There's some higher level of intensity we need to get to, but it just adding here didn't work. So what about this in the auto maintenance term I dislike, maintenance therapy, which should really be consolidation therapy because you're not maintaining anything, you're trying to further knock the disease down. And this is just to remind us that in all of these studies, as Hari pointed out, relapse is early. So if you want to do something, you have to get it in early. And things you can get in early would be Rituxan, because it's not very toxic, but overall, when they added Rituxan maintenance in large cell lymphoma to an auto, it didn't do much. It may in ladies, and we don't have time to discuss that, so we'll skip that. But maybe it was a wrong drug. So Dr. Fenske's one and his group from Milwaukee, being led by Tim, are wondering whether ibrutinib, a better drug, might be the answer. Maybe Rituxan was the wrong choice. And so they're doing this study to see, and the trick will be whether they can get the drug in soon enough to make a difference. And if it doesn't interfere with the GVL effect, we'll have to see. So what about allos for lymphoma? Hari talked about that in my usual sort of brief summary. You increase the intensity, you get more TRM and less relapse. In practice, it isn't that simple though, right? Because there's a wide age range. The DRI is all over for lymphoma. Everybody's different when they come through the door. And the people who you decide to give a Seattle approach or a RIC or a MAC are not the same. So even patients with the same sort of features on paper are not the same when they're sitting in front of you. And I personally can't make any sense of this. I don't know what this tells us. This is sort of, you know, it's just a mishmash. So I think what we do is this. When we see younger people who have a good KPS, low comorbidity, it's been a while since they had their last treatment, they didn't get a perfect response to salvage and their disease risk is high, I would do an ablative conditioning. If you can get the therapy in and you have a reasonable chance you're not going to kill them, we know that there's a benefit of intensity. Same patient, but they had a CR to the last therapy. You might say, well, disease risk isn't quite the same. Maybe I've got a little time for the immune system to come in without having to knock them down so hard, so I'll do a RIC. And if they're old and they have a high comorbidity index and they've had a prior auto, and you're going to transplant and you're kind of stuck, you might have to probably have to do a RIC. Now, you might get different results, but you'll be stuck with that. So this is 2 slides on this. So sometimes the conditioning regimen, its intensity and it's where the disease is, and you have to get the regimen into the disease. So in primary or secondary CNS lymphoma, autotransplant, there's a fair amount of data that it's beneficial in phase 2 studies. But the best results are if you actually give drugs that get into the CNS. And so we use this thing we call the Alberta protocol, because this guy from Alberta started it. And the conditioning regimen is the salvage was high-dose methotrexate and high-dose cytarabine, and then the transplant is with busulfan and thiotepa that both get in the CNS. So sometimes it's intensity and where the intensity needs to be delivered. Just like we said, if you gave radio-labeled antibody in AML to something that goes to the marrow, that's a great idea. So intensity matters. What can we do about it? Well, you can transplant earlier. All the bad things happen to people who we beat up before we get them to transplant. So don't wait until the myelofibrosis is killing them. Transplant them earlier. Because all of the bad things happen if you wait. Pay attention to the details. I told you at the start that the only real advance we've made is in supportive care. So do the supportive care right. Give ursodiol. Like I always loved that. Hari said, you know what, we started 2 months early in the patients because we're going to help them. Look out for drug interactions with your busulfan, right? And make sure you consider those issues. Use therapeutic drug monitoring. If you want to push the dose in high-risk patients, do PK, push the dose. MD Anderson has shown that works. Seattle's shown that works. Seattle does ablative transplants and myelofibrosis with PK and get the same results as everybody else does, in terms of TRM. How are you going to dose overweight patients? I've thought about that a lot because we're getting fat people in Canada now. And think about where you're targeting and what drugs can target where you're going. Match the patient to the intensity, right? Don't just look at, the age. Don't just look at the comorbidity. Think about them in a sort of in a gestalt to put all of those, including the disease risk index. And if you're not sure, can we do a more thorough functional assessment? So Andy Arts from Chicago does a full geriatric assessment on everybody over the age of 55. I'm 54, so I'm okay, but in 6 months that would mean me. But he's shown it makes a difference. You can identify people. A lot of people have some compromise in their functioning. That doesn't mean you don't transplant them, but you're aware of it, and then can you improve upon it? Well, exercise didn't really, it improved a little bit their function, but it didn't improve the outcome. But it doesn't mean that's a lost cause. It just means we have to more research. Biomarkers, he had published, I think Harry might be on the paper, you do a CRP and it tells you if you have a high CRP before transplant, you're doomed, and if you don't, you're in good shape. That's a bit too simplistic for me, but it may be part of a package of things. Separate the intensity and the immune effect. So we know we need both. Do the auto first with high-dose therapy, then come back with a reduced intensity allo. So we do that in our lymphoma sometimes. We do an auto, then a reduced intensity allo in a planned tandem. Sometimes it's because you can't get the allo organized in time. Sometimes it's on purpose. The myeloma people, we did it with the CTN. I was part of that study. And I think in another 5 years we'll see that the allo people are still cured and the auto people have all relapsed. They've tried it a couple places with where you give a high-dose chemo regimen for the AML and then you come in with a low-intensity conditioning. Ollie Ringdon published, and he thought he had he was like, oh, this is so promising, but the three-year leukemia-free survival is 25%, so I'm not sure it's so promising. But then in March, one of the March versions of Blood, there was an article that did this similar approach and had actually quite good results, so it's in the details. So, second last slide, what if you can't intensify? What else can you do? So we think intensity matters, but you can't get there. What can we do? Well, you could do post-transplant interventions. Buy time until donor immunity kicks in. My big thing is, can you get the drug in? Can you get the drug in the right dose, and you can get it in soon enough? And so far, I've not been convinced. I've not seen much that says you can. You could use disease-specific targets, or you could use general targets. So TKIs, everybody's doing that, right? If you have CML and here I going against what I said, you have minimal residual disease after, you try and get them on ibrutinib. No randomized control trials, but it's probably a good idea. Hari talked about IMiDs and myeloma, Marcos about Vidasa, John DiPerzio combines Vidasa with low-dose Mylotarg, Tim Fenske's trial about ibrutinib, ipilimumab or nivolumab have both just recently been published as that you can give PD-1 inhibitors post-allo transplant without everybody dying from uncontrolled GVHD. That's the first question, right? You put in a new immune system, it's 50-50, it's going to give you GVHD, and then you set it free. You don't know whether it's going to go kill the GVL or kill the patient. So these guys have shown that, at least in some of the patients, you can do that, and this just shows this is ipilimumab before and after treatment with relapsed leukemia post-transplant. The old school, accelerate GVHD, taper the immune prophylaxis, give DLI, or based on MRD monitoring. And as I showed you the last talk, there's lots of magical and what I think is flawed thinking about MRD and its interventions, and Bob Gale wrote a lovely piece in BMT in 2014 about that. So in summary, there's more to conditioning than the regimen. Autos and to some degrees allo depend on cytotoxicity, so intensity does matter. Matching the regimen to the patient and sometimes to the specific disease is important, like in CNS lymphoma. Dose escalation is hard, right? You go up from where we are and we get too much TRM, so we have to target the intensity to the disease or where the disease is, whether it's a CNS or it's in the marrow. Total marrow irradiation using tomotherapy. We have a protocol where we're up to 24 gray total marrow radiation and second myeloma. You get 1,000 gray to the lungs, you get 2,400 to the cervical spine and the ribs and the pelvis, and that potentially a way of intensifying things. Post-transplant interventions will be tried in autos and allos for sure, and I actually think they'll be helpful in allos more so than they will be in autos because they're buying you time until you have an allo effect. In the auto setting, they're all you have. They're not buying you anything other than it's another form of therapy, and most of those patients have already seen a lot of those. And then the details matter. Supportive care is still probably one of the most important things we can focus on. And with that, I'll take questions.
Thank you. A comprehensive talk. We can take only a few questions or suggestions from audience. Yes, please.
Thank you. For a myelofibrosis patient with excess blasts or blastic clusters but not leukemic transformation, would you go for induction first and then RIC transplant, or just directly to a myeloablative transplant?
So that's the same school as the people who induce MDS or don't induce MDS. I personally don't think that the induction adds a lot, and I don't have data, but you run the risk of buying toxicity and precluding the patient from transplant, and you know that in that setting that the induction is not going to cure them. So I would rather in that setting use an intensive regimen if I could, like a full flu-bu, or with targeting with busulfan and pharmacokinetics, and do it all at the same time, because I don't think the chemo there is very good induction in that disease setting. But Hari has way more experience than I do.
Yeah, it depends on whether it's myelofibrosis. So I think we have two situations in that thing. If it's myelofibrosis, true myelofibrosis with high-ish blasts, you're just okay to do the transplant. But if it's an MDS, MPN with rapidly proliferating disease, I tend to do either azacitidine or decitabine for a few cycles, and then do an intense, if they still have high blasts, tend to do an intense regimen. But I would never do a typical induction 7 and 3, because I think I agree with Chris there. You're actually, if you're going to do a highly intense regimen, you're better off doing it with the transplant, because then you do it only one time.
Last question, please.
Thank you. It's a specific question. There are some protocols combining sequential chemotherapy with RIC, especially for patients with high-risk AML. Do you think this strategy works, or do we have to force the patients for immunoablative conditioning?
So I touched, probably went too quickly, I'm sorry. I touched a little bit on that. So Ollie Ringdon just published something at the end of 2016 where they gave this FLAMSA regimen, fludarabine, amsicrin, and something else, Arac maybe? Yeah, and then like 14 days later did a very low intensity RIC transplant. And as I said, he said his results were very promising, but they only had 23% survival, so I don't think that's very promising. On the other hand, like just in the last week or two in Blood, there's another group, I think it's a German group, because they seem to be able to do these things. They did the same type of thing, intensive chemotherapy, a couple of weeks later, reduced intensity allograft, and they had something like 60% survival in what they thought were high-ish risk patients, and it worked. So I think the principle is not a bad one, but in select situations, because if you can tolerate an ablative transplant, that's what you should do. Some of my colleagues are like, if you can't tolerate an ablative transplant, you shouldn't have a transplant. But if you can tolerate an ablative regimen, you should just get on and do it. If you really think that you're worried about the toxicity of that, and then that being superimposed on GVHD, that combination will be too toxic for the patient, then it's not unreasonable to separate them. I don't think it does what people originally thought, which is significantly decrease the GVHD risk. I think it just means that you're probably in a little bit better shape if you have like an auto, recover, a month or two later have an allo. But I don't have any randomized data for that.
Thank you again. We have to keep on next speaker. Next speaker, Professor Gürgün Akbek.